Okay, I'm not sure when my video just shut off, but we'll try it again. So I was talking about ways to help your patient reduce their intracranial pressure. You keep their head in alignment. You keep their head of the bed up at 30 degrees, at least 30 degrees. Mannitol, Decadron. Keep the pain under control. Pain will increase ICP. High oxygen, low carbon dioxide. Prevent shivering. Okay, so I think I told you about most of that. Okay, so now I wanted to talk about cerebral perfusion versus intracranial pressure. You kind of need to know this. Your CPP is your cerebral perfusion pressure. Your body works very hard to maintain perfusion to the brain. Basically, that's what that means, is how well that brain is getting perfused. So to figure out what your cerebral perfusion pressure is, you take your mean arterial pressure, and you guys know how to figure this out from Med-Surg 1. Your mean arterial pressure is your systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. That's your mean arterial pressure. So you got to figure that out first if your patient's not on a monitor to tell you. And then you subtract your intracranial pressure, and that'll give you your cerebral perfusion pressure. So normal is about 70 to 100. And that's where you're going to want to maintain that. So you watch your patient's blood pressure, if that's getting high or low, and it's altering that mean arterial pressure. If your ICP is getting too high or too low, then that brain is not getting perfused adequately. And so that's why these numbers are so important, because your job as the nurse is to make sure that that brain is getting perfused. So because if that brain is not getting perfused less than 50 millimeters of mercury, this could end up in permanent neurological damage because the brain tissue is not getting the oxygen that it needs. This would be equivalent to the heart not getting enough oxygen and having an MI, myocardial infarction. So how do you know what your patient's ICP is? Well, you can determine some of those things by looking at the Glasgow Coma Scale, assessing if they're posturing, things like that. But a lot of times your patient, if your patient is in the ICU, they will have intracranial pressure monitoring, and we can do this a bunch of different ways. You can just put a bolt into the subdural space. This is called a subdural bolt. The intraparenchymal sensors, just right down in here, and then these are all hooked up to sensors that'll tell you what the pressure is. A subarachnoid screw, again hooked up to sensors, or an actual ventriculostomy, where this is a catheter that goes right into the ventricle and sits in the ventricle. The thing about this one is that not only does it monitor the pressure, but you can also drain off cerebrospinal fluid if that intracranial pressure gets too high. That's called a ventriculostomy. All of these will monitor pressure, just like an automatic blood pressure cuff, but this one will actually be able to pull out cerebrospinal fluid if your patient needs that. If your patient needs a ventriculostomy, the catheter will go into the ventricle, and then this part is hooked up to the transducer, and then there is like a little bag over to the side, a collection bag. This would be similar to like a Foley catheter. And then what you have to, you've got to mark this at the 0, and they mark it pretty much right at where basically where the tentorium is, like right at the ventricle mark. So you lay your patient flat, and right at where this little flap is at the ear, you make that your 0. You 0 mark it there, and then the neurosurgeon will tell you where to set this monitor. So if he wants, let's say that he wants to keep the ICP less than 20, so you would set this at the 20 cc mark. So if the ICP, the intracranial pressure, gets higher than that, it will go up into the catheter and then drain into the bag, and that's one way you can pull off cerebrospinal fluid. You do have to be really careful, because if this falls down because of gravity, you can drain the whole cerebrospinal fluid. So if your patient has this in place, they're probably going to be in the intensive care unit, and you're going to be a highly trained nurse to take care of a patient who has this in place. And also, infection is a huge problem, because now you've got this catheter going right into their brain. So that it's a little bit higher level of nursing, but it's kind of cool. There's a bunch of different kinds, and it will tell you, it gives you like what the patient's temperature is, what the patient's intracranial pressures are doing. So there's a bunch of stuff if you end up working in the intensive care unit. Okay, so a couple other things just really quickly before we close this. Intracranial surgeries, I've already told you about the different locations of it. Basically, it's just an opening in the skull. The table 66.3 in your book has a pretty good example of some of the different intracranial surgeries. These are burr holes. A neurosurgeon can go in and just drill a hole into the skull. They would do this to maybe take out a biopsy. If the patient has a brain abscess, they can go in and drain it. These are nice because they don't have to open up the entire skull. They just take out a section of bone, and then they would just put the skin back over it, and that usually fills back in. Pituitary tumors, I don't know why this is located, excuse me, I don't know why pituitary tumors are located in this chapter, but they are, so I'm going to just tell you about pituitary tumors. A pituitary tumor, if you'll remember from endocrine, your pituitary gland sits right at the base of that brain. So oftentimes what they'll do is a transphenoidal, trans meaning across, phenoidal approach. They will go right through the nose and back in there to where that pituitary gland is, and they will remove it. And they don't have to open up the whole head, which is nice. They just go right in through the nose. They can visualize it, usually using robotic surgery, go up and pull the tumor off of the pituitary gland. What you watch for in your patients, they'll usually come back to the intensive care unit at least for 24 hours of observation. Make sure that this isn't bleeding. You do not want that patient coughing or sneezing or putting any extra pressure on there at all. They're going to be sitting up. The thing that you watch for with this, and if you'll remember from our endocrine lectures, is remember all the stuff that your pituitary gland is responsible for. Well, if you go in there and pull something off the pituitary gland, now you have all kinds of hormonal problems. One of them that you're going to see initially is diabetes insipidus. The patient will start urinating a ton because they are losing their ADH. If you'll remember that, we can go over that again in class if you want. So you have to be really careful that they're not getting hypovolemic, because they just lose massive amounts of fluid. We do have some medications that we can treat that with, like DDADP and some other hormonal things that kind of calm that down, but that's one thing you watch for. The other thing I want you to study this week is seizures. There are some specific causes of seizures. So some people have seizures for a very particular reason. They have like tumors. I've told you about my dad started having seizures because he's got a tumor. People that have high blood pressure, brain tumors, drug or alcohol withdrawal, certain allergies, head injuries can cause it. So there's a lot of specific causes of seizures. There's also some non-specific causes, reasons that we don't know why people are having seizures. And those are your patients who have epilepsy. And so I do want you to study a little bit about the different kinds of seizures. There are petit mal seizures, grand mal seizures, and varying degrees on that. So I want you to kind of look over that this week. And the other thing this week is headaches. You don't need to know this word. Nobody will ever in healthcare use that word. Everybody calls it a headache. But it is really, really a common problem. Everybody and their brother has headaches. You do need to kind of understand the cause. If you can remove the cause, then you're going to remove the headache, which is the goal. So things like stress can cause it. So if you can reduce stress, lack of sleep can cause it. There could be primary headaches. There can be a secondary headache. Headaches from brain tumors. Some people have migraine headaches. Some people have cluster headaches. So your job as a nurse to figure out the cause and fix it. And if it's a migraine headache, migraine headaches are usually caused by vasospasm in the brain. So there's specific really good drugs on the market for that now. So just kind of look over that a little bit this week, and that is it. Let me think. Did I tell you everything I wanted you guys to know this week? Yeah, kind of study. I thought that table 66.1 in your book was pretty good about some things to assess for when you're assessing your neuro patients. But I think that is everything else that I wanted you to know. Some with headaches, people that have family history, some current medications. So just kind of review that a little bit. So, okay, so that's it for this week. Sorry that was in 2 parts. I'm not sure why my videotape shut off there. So, okay, that's it. We'll see you next week for chapter 67.